All right, we're going to go ahead and get started with our speaker today. I'm very excited to introduce Naomi Chaytor. For those of you who don't know, and this may date me, so I won't give any years, but Naomi was actually my second student to graduate with her doctoral degree way back a long time ago, and she has had an interesting career of doing some clinical work at UW, actually supervising some of my later students who were on internship at UW, and then recently coming back here in a faculty position. She just got tenured.
Was told it's not effective till July.
Okay,
so.
but we're very excited about that. And this is your third year here now, or second?
Third.
Third year.
Yeah, so it'll be 3
so
years in August.
Yes, so she's up at the Elson School, what do we call it?
Elson S. Boyd College of Medicine.
Okay.
Your third year?
Pardon me?
You got tenure in your
Oh, well, I was already an associate professor at UW before coming here, so it was, I was doing clinical work and research, and so I, after 3 years, yeah.
Yes,
Yeah.
yes.
Yeah.
So Naomi also has the honor of having the most, for me, the most cited publication that I have is actually Naomi's preliminary paper on the ecological validity of executive functioning. So those of you who have used that paper a lot, this is the person who wrote that paper way back then. But she has gone on to do a lot of very interesting stuff, and most recently has started doing a lot with diabetes. And so that's what you're going to be talking about today.
Yes.
So without further ado.
Yeah. Thank you. And definitely ask questions during the talk. I prefer that than waiting till the end, so I like questions. So there's sort of a couple different parts to this talk, and I'm trying to kind of focus it on the technology side, given the context here. The work that I'm doing around the technology is sort of in clinical trials right now, so I don't have data yet, but I'll talk a little bit about what we're looking at, and but do have some other data that I'll share with you. Okay, so what is type 1 diabetes? Just put up your hand if you know what it is, the difference between type 1 and type 2. Okay, so pretty common that a lot of people aren't real clear on that distinction, so good, because I'll go through it. So type 1 diabetes is an autoimmune disease affecting the insulin-producing cells in the pancreas. So it essentially means that the body stops making insulin. And insulin is a hormone that's needed for glucose to get into your cells in your body, to fuel your body. You have people who with type 1 diabetes have to inject insulin to stay alive. But the side effects of insulin can also be deadly. So it's a really tricky balance that before they discovered insulin, everyone with type 1 diabetes would die within a certain amount of time. So it was a really substantial, in 1922, they figured out, some Canadian researchers, I'm Canadian, it was kind of our most important contribution to science. We're able to create insulin, a miraculous cure for all of these kids, typically at the time. So the consequences, though, of artificially providing insulin are that you don't give enough, which would mean that your blood sugar would go high. And in the extreme, that can lead to a thing called diabetic ketoacidosis, where basically the body starts breaking down fat into glucose, and that's sort of only can happen for a certain amount of time before it becomes toxic to the body. And in people with type 1 diabetes, this can happen rather quickly, within a matter of a day or two, if you were to not get any more insulin. Whereas with type 2 diabetes, this can also happen, but it's a much slower, more gradual process. The consequence of having too much insulin is a low blood sugar, hypoglycemia. And this can result in loss of consciousness, coma, death within an hour potentially of onset. So there's sort of this range that people have to stay within to kind of be in that optimal zone, and there's danger on both sides. Long-term complications, this is similar to type 2 diabetes with high blood sugar, are all those things that you sort of hear about, kidney disease, blindness, nerve damage, heart attack, strokes, or vascular outcomes from type 2 diabetes are the same with type 1 diabetes if blood sugar stays high. So the onset is different also. So typically, it was thought it was called juvenile diabetes. The name has been changed, and that's no longer the title because it is not only diagnosed in children, but most people still have that assumption. And in fact, a recent study came out, a large sort of countrywide, I think in Norway, study that found that half of new diagnoses of type 1 diabetes occur over age 30. Annual associated healthcare costs in the United States. There is an increase in incidence, new onset of type 1 diabetes. I'm not sure why, but across the board there's increasing prevalence.
I know like type 1 has a genetic component to it. Are they seeing that increase even like that they're getting it, like people are getting it at an older age as well, even with the genetic component?
Yeah, so there is a genetic component, but it's very multifaceted, and it's a sort of gene-environment interaction. So people can have the genetic markers and never develop it, and there's a wide variety of genes that can indicate a risk. And then there are some environmental triggers. So a lot of the research around why the incidence is increasing and also sort of increasing, it's a separate issue, but increasing in adults has to do with sort of things like gluten in the diet, or when children are exposed to certain things, sort of autoimmune types of factors. It is more common in northern latitudes, similar to multiple sclerosis, for example. There's racial disparities in type 1 diabetes. It's much more common in Caucasians than, so there's a vitamin D link to it. There's all this sort of stuff. So it's complicated. With adults, some of it may be actually accurate diagnosis. So people in the past would have been assumed to have type 2 diabetes and just would be moved to insulin really quickly because oral medications weren't working. And then they just never investigated whether they had type 1 or type 2.
And I've been hearing a term thrown around type 1.5.
So that's sort of that adult onset, and it used to be that people with type 1 diabetes were pretty universally thin, and that was because you start burning fat when you have high blood sugar. So often people would be more on the thin side. So that's what physicians would there's no insulin resistance, for example, like you see in type 2 diabetes. But now with better control and this adult onset, people also have insulin resistance because there's more obesity, just like the general population. And so you get some features of type 2 diabetes because of the insulin resistance that can go along with obesity and inactivity. So they have features of both. But to have type 1, you have to have the antibodies for the beta cells in the pancreas, and you don't produce insulin. Because type 2 will eventually not produce insulin, reduce the insulin production, but not at the beginning, and that's the distinguishing feature. Good questions. There is also a rising life expectancy. So in 1975, so this was right when, so people, 1922 is when they discovered insulin. So in 1975, they did a study, your life expectancy was on average 27 years less than the general population. With improvements in insulin and treatment regimens. That's 10 years ago, it was down to 13 years. It's probably better than that now, but it takes a long time to do these studies. So people are living longer. But less than a third of people in the United States are achieving target blood glucose control levels. So that range between high and low, only about a third of people are effective in that. And it's very common for people to have hospitalizations, EMTs coming to the house, ER visits due to hypoglycemia or diabetic ketoacidosis. So problems with management. So this is sort of where the focus here on the technology comes in, but you need to know a little bit about what's involved in taking care of this disease from an individual standpoint. So, we hear about type 2 diabetes being like a chronic disease, self-management being really important, and diet and exercise and all of those things. It's ramped up 10 times or more in type 1 diabetes. So the core things that a person needs to do on a daily basis, and usually multiple times a day, is to check blood glucose. And there's lots of different ways to do that, but the traditional is finger stick blood glucose to know where you are. To administer background insulin, so the body needs to have a certain level of insulin in the bloodstream at all times, and if you don't produce it, you need to replace it. So that's this long-acting insulin that people will have to inject at least once a day. And then you have to give insulin before eating anything. And that would depend on how much carbohydrates you're eating in that meal. So the amount of insulin depends on how much carbohydrates. And that's with every meal, every time you eat. And then sometimes your blood glucose will be high, even if you've done those things. And so you have to be monitoring that and correct with insulin when it's high. And when it's low, you have to eat a fast-acting, like sugar, juice, that kind of thing, to bring it back up. And then you need to, over time, track and review sort of these patterns and figure out, okay, I did this and this happened, so I need to give more insulin or less insulin and adjust that over time. So it's a pretty heavy daily burden. Yeah?
If people exercise, don't they have to check? Do they have to check right after they exercise, or do they recalculate?
So exercise leads to hypoglycemia. So the glucose that's in your bloodstream gets into your muscles through exercise, and so that's a dangerous time as far as, especially if you have artificial insulin. It actually works faster than our normal insulin. So people have to eat more carbohydrates when they're exercising, reduce insulin, check more often. And most people will experience symptoms when they have low blood sugar. So they'll know, and it's kind of adrenaline is the first level of response. So that sort of lightheaded, sweaty feeling everybody's probably experienced to a certain degree if you haven't eaten and maybe exercised. But it's much more dramatic and fast. And then if you don't have sugar after those symptoms, you actually start to get cognitive impairment, motor issues, that kind of thing. And if you don't treat it before that, then you can get confusion to the point of like not being able to correct it or loss of consciousness. So a lot of times people will feel that their blood sugar is low, like while exercising, and then they kind of get prompted to check. People do lose those symptoms over time, and so that can be, it's called hypoglycemia unawareness, and I'll talk a little bit more about that. In addition to the sort of daily regular management stuff, you also have to do the things like any medication to get refills, but you also have testing supplies like test strips and needles and syringes and all of this other stuff that you have to order and make sure you have. Also, glucagon is similar to an EpiPen, but for low blood sugar, where it's a rescue medication if somebody's unconscious that someone else can administer. So having that with you is kind of an important thing. And always carrying sort of a minimum amount of stuff with you at all times. And you have to remember to bring things. There's also sort of long-term preventative care, eye exams, foot checks, blood pressure, lipid management, other things that you're at higher risk for developing. So you have to kind of manage all of that other extra health care. Plus, these are people often that are diagnosed in childhood, young adulthood that are working, that have children, that are going to school, that have everything else that anyone would be doing, plus all this other stuff on top of it. So as you can imagine, it's pretty cognitively demanding. And this is just one of these like common internet jokes around type 1 diabetes. And so bolus is another term for the amount of insulin that you would take at a meal. And when you look at food, you have to be able to estimate how much carbohydrate content is. So that picture on the left, I wouldn't advise eating this meal necessarily, but that's the carbohydrate content of those foods that you'd have to add up. So to give you a little flavor of what that's like cognitively, if you were at the talk I did in Maureen's lab a year or two ago, this is the same one, so you have a little bit of an advantage. But so then this is assuming you have a nutrition label for what you're eating. A lot of times we don't. But you are going to eat 4 ounces of pasta. Assume you weighed it, which most people won't either, so the portion size is an issue. Your insulin to carbohydrate ratio, meaning the amount of insulin you take for the amount of grams of carbohydrates, is 1 unit for every 15 grams. If there's more than 5 grams of fiber, so fiber is a type of carbohydrate, but it's not digested or converted into glucose, so you would need to subtract that amount from the total. So given you're going to eat this, how much insulin should you take? And you can't write it down because people are unlikely to have paper or calculator when they're, out at a restaurant. So if you put up your hand, lots of graduate students too. This, we're excited to give this. What? 3 units? Okay. Any other guesses? Yeah. 2 1/3. Any others? Yeah. 4.
It's gonna be like 6 because it's 4 ounces of pasta and the serving size is 2 ounces.
Okay, so 6 units.
Yeah.
Okay. All right, well, I'll show you the math. So it's 4.7 units, so you would have had trouble because you would have had a hypoglycemic episode for sure. And then the 3 back there, you probably would have had to correct later for that. So the difference between, so if a person took an extra unit, depending on sort of if they're at this level of insulin sensitivity and didn't then correct that low blood sugar, like in that case, that person could go into a coma and die. Like that's the amount of wiggle room you have, okay? So imagine you were doing this kind of calculation while your kids are yelling at you that they're hungry for dinner, or you're having a dinner conversation at lunch with someone. Obviously it becomes somewhat automatic the more that you do this and you're more familiar with it, but there's still a lot of margin for error. Like say you forgot to account for the fiber, or you didn't have a nutrition label so you didn't know, or you didn't adjust the serving size. So there's a lot of ways that people can go wrong with just this one element of diabetes management. And that's not the only thing that affects blood sugar. So this is a list of the 42 common factors that affect blood sugar. And you'll see that food, certainly on there, carbohydrates, type, amount, quantity. But there's also things like timing of the insulin relative to when you eat, interactions with other medications, things like steroids increase your insulin resistance, biological factors like sleep and illness. If you've had a hypoglycemic event within a certain amount of time, you're more at risk for another one. Different sort of hormonal issues, if you have other medical conditions, environmental things. They just did a study that the insulin content, potency of insulin varies very widely across manufacturers or even within manufacturers. So the insulin you're taking from one vial could be twice as potent as the insulin you're taking from another, but you wouldn't know that. And then there's also this little box that they added recently to this list. It used to be 22, and now with research, it's changed to 42. So there are also things about what the person does in response and the decisions that they make. So this is a sort of small example, but a common one. So if my blood sugar is high, I need to eat 60 carbs, and I'm going for a run, and I feel a cold coming on. So these are factors that some may lower your blood sugar, some may increase your blood sugar. How much do you take right now, right? So you'll notice that these arrows next to these things, some of them are up and down. So it could either increase or decrease depending on the context. So it makes it very complex. And no person can kind of take all of these things into account in any one situation. So it begs the question, this is a lot of data, this is a lot of information, how can technology help with this task of managing diabetes? So the sort of lowest tech thing that they recently came out with is, so insulin pens is the default, kind of cheapest way of just injecting insulin. But the problem with this is a lot of times people will forget whether they took it or not, and there's no way to know. It's not like you can count the pills in a box. There's something that you could check. And then if you gave it twice, which some people will do, it could be really bad. If you don't give it, then it's going to be really bad. So one of the things that they've done recently is have this kind of computer component to the insulin pen that will record the dose, and it goes to an app so you can sort of track it over time. There's insulin pumps, which have been probably the oldest, besides just finger stick blood glucose meters, the oldest tech in the type 1 space. So this is a pump, as it's called, and a small needle that is permanently, like you attach an infusion set to your body, and the needle stays in there, and there's a tube to the pump, and it will give you background insulin throughout the day, just like a pancreas would, and then you enter in the amount of carbohydrates you're eating, and it will calculate the math for you. You still have to figure out how much carbohydrates are in the food, but it will do all of the conversion to the amount you should take based on your ratio of insulin to carbohydrates. And it also does things like, if it's a high-fat meal, it'll spread the insulin out over 2 hours instead of giving it to you all at once, some other sort of features. And that's been shown to greatly improve control by using a pump. It allows you to eat in between meals much more easily because you can, give yourself small boluses whenever you're eating. The bigger thing in terms of the tech here is continuous glucose monitoring. And this has been around probably for about 10, 15 years in some capacity, but only recently has it become accurate. So they used to have, I think one of the first things was a watch. It was GlucoWatch, I think it was called, and it did some sort of sweat glucose sensing on your wrist, but it was like very inaccurate, and I think it burned people, and there was some stuff with it. And then they had sort of first generation continuous glucose monitors that have a sensor that goes under the skin in the interstitial space between cells, and it was very inaccurate, and so people wouldn't wear them because it's giving you information that's wrong, and it would be inconsistent with a finger stick. But it's become to the point now that the newest one that was just FDA approved is now better than the finger sticks in terms of accuracy with like direct blood glucose measurements. So it's better than the finger sticks, so very accurate.
And how does that one work? Is that under the skin?
I'll show you pictures, but yes, yeah. And there's a couple different brands. All of these, there's like different versions, and some are better. But this has so basically it's showing your blood glucose on a screen every 5 minutes continuously. And it also, you can set like an upper threshold and a lower threshold of blood glucose values that it will buzz, alarm, do whatever to alert you that your blood glucose is low or high. It also has direction of change. So based on sort of the slope of the measurements before, it'll tell you that you're raising it like an arrow diagonally up, double arrows that show that you're rising really quickly or dropping really quickly. And sort of if you did nothing, your blood glucose would be like 100 units higher in this amount of time. So it gives you that type of preemptive information. They also have smartphone apps that go with them that can then share information with a family member or significant other, so that they would, say a kid at night, the parent or kids at college would know that their blood sugar was low and could text them and say, are you doing something? Beyond these two kind of separate technologies of giving insulin and measuring blood glucose, they've now started to integrate the technology together. So the sort of most basic form of this is a display only. So it just has the continuous glucose data and a graph on the pump so that you can directly, enter in how much insulin you want to take based on what the blood sugar is doing. Used to be two separate devices. They now have sort of the first level of automation as a low glucose suspend. So it'll turn off that basal insulin before if your blood sugar is trending down to a certain threshold. So it'll stop that basal, which can help correct it automatically. And there's one FDA-approved hybrid closed loop where it also administers insulin. So the full closed loop system would be that the pump is operating on the continuous glucose monitoring and giving insulin when it goes up and stopping giving insulin when it goes down. And there's versions that also give a hormone that will raise your blood sugar rather than just stop the basal. The current one is not fully closed, so it will correct for highs, but you can override it you still have to enter in the carbohydrates you're having in bolus for meals. But the fully automated one is you do nothing and it just operates. But that's not FDA approved yet. That's not prime time. It's a lot of safety issues if it malfunctions, if there's a problem. All of this has to do with the accuracy of that sensor, because if it's not accurate, it's bolus, say it says that you're really high, gives you a lot of insulin, but you're not that high, it's a very dangerous situation. So one of the problems, though, with this hybrid closed loop is that people are going to open loop, so they're not trusting it and using it very much.
How accessible are these devices, especially for like low-income folks, or like how much support do people get with learning and managing this very complex
So
device?
it's not good in terms of cost, so they're expensive. Some insurance companies won't cover them. Some will only cover a certain brand that may not be the best choice for that individual. There's one CGM on the market that is less accurate than the other one, but that one is integrated into a pump that a major insurance company will only allow you to have that pump, so you can only get that CGM, basically. So they're going to these proprietary sort of systems in some ways that people are really mad about. And they're really expensive. So like the CGM one sensor is $10 with insurance, and that's like a week. So just the sensor plus the insulin is ridiculously expensive. So just the baseline staying alive with type 1 diabetes is pretty expensive. But then you add these technologies that change every couple years, it can get quite costly and prohibitive for a lot of people. The CGMs were about 9% of the type 1 population was using them about 5 years ago, and now it's closer to 25%, but still the majority of people are not, and probably a big part of that is cost.
How much like medical staff support is required for this? Because like just like going through basic medication pill stuff would require sometimes someone to sit down and talk to them about like, okay, like this is how you're managing it. Let's talk about strategies.
Right. So
Is
there's
there
a
support with this?
Yeah. So the ideal way that you start somebody on these technologies is that you do a fair amount of training. There's certified diabetes educators that would spend that time kind of tailoring it to the person. But you can buy these, just like contact the company and get a prescription and start it yourself, depending on what your doctor will kind of write a prescription for. But the question that I have, to bring it to the Gero side of the technology, is are there populations that either this technology could help reduce the cognitive burden, or are there issues like that of the technology and you maybe need more supports to use if you're older or have cognitive problems? So that's an open question as to, I think it could go each way. I think you had a question.
So as you said, these pumps are really expensive and insurance is not going to pay them. I don't know, like a year ago I was documenting WISE, and there was a group of people who have diabetes. They make an open source project and make this pump. Is it accurate and working?
Yeah, so it's called Open APS, Open Artificial Pancreas System, and Night Scout is their thing, and so it's all probably people like you, the technology side of the group here, that started. They're computer scientists that developed the algorithms themselves, and they're using existing pump and CGM technology, and it actually is probably what spurred the companies to do this, because there wasn't a lot of movement before that started. And the same thing with the share feature on the CGM. That group figured out how to just hack into it and using like cloud platforms to send the data from the CGM to a smartphone. So they did that, figured out the technology themselves, and then to be competitive with that, because they saw it as like patients wanted this, it was really hard for people to do. It required a lot of setup that was pretty technical. So it was only kind of people who had the intellectual privilege to do that did. But then they made it commercially available in response to that. So they actually did almost no research on it, but they did it because it was something that the users were demanding. And there's several startup companies that are kind of people who were involved in that. initial sort of closed-looped thing, that are now starting companies to sort of fill that need for people that are a little less tech savvy. Because that's sort of the problem, is it was then only available to people who had the skills to be able to do that. But it is pretty accurate. There's different algorithms, right? And that's a place where there's a lot of research in terms of what is the best way to control blood sugar and to respond, given there's so much variability in what people do, and the amount of user input that you want. So there's a lot of variations on this, and that's just like one solution. But yeah, people are doing it, and I mean, there's no research on it, so we don't know how safe or not safe it is, and that's the danger. Yeah.
I think I can maybe anecdotally answer the question you posed, the open question. My dad had type 1 diabetes and actually had a hypoglycemic episode and ended up having a severe traumatic brain injury from getting in a car accident.
Oh, wow.
And so he was one of the first people actually to get a pump because it got so complicated for us to manage insulin, and because he couldn't remember if he took it, he couldn't remember if he tested it, and there was so much of our lives was around chasing him around to poke his finger before he would go get in the car, because it was just he didn't think about it. And I think the pump was it still was a lot of work. Thankfully he was an accountant, so he was able to do his calculations pretty well. So we didn't have to worry about that part, but that was such a time saver that, that was back, I think he got his pump in 2000, really one of the first. And
they actually had backpacks in the 1970s that it was that big, they had to carry around. So a lot of it is making them smaller.
Yeah, so that tiny, he was the first one to get, one of the first people in a clinical trial to get that tiny little, because he had hypoglycemic unawareness as well, so it was really difficult to manage. And I do think it will help, but it does still require a caregiver.
Right, so that issue of the cognitive stuff, so somebody who had a brain injury, but more broadly the general population, how much is that a factor? And that's the thing that I'm sort of interested in. The other thing, just briefly, there are smartphone apps that are kind of more in there's just diary type tracking apps, but there are decision aid apps too that are getting more and more sophisticated in terms of you get all of this data and how do you kind of interpret it. So these are the devices, just a smattering of different devices. This is the full closed loop, which really is just the addition of a cell phone that has an algorithm in it. This is the hybrid closed loop pump. So you see this is the continuous glucose monitor. This is where the insulin is going in. There's a graph on here. This is the current blood glucose, and it will do some things automatically. This is the sort of industry leader continuous glucose monitor from Dexcom. They are back to a watch, but it's a smartphone app. So it's still working, or you get a phone app. And this one is just a integrated pump, and right now it doesn't do any interaction. Mm-hmm.
Please let me know if I'm asking too many questions. But I guess what I first see, how does adipose tissue and just the propensity of just getting infection play a role in this pump?
Yeah. So adipose tissue actually doesn't matter because this is interstitial space, so it's between cells. So it's actually supposed to be in somewhere where there's fat. If you have insulin directly into the muscle, it acts super quickly, and that's a rescue. If you want to lower your blood sugar really fast, they'll inject into the muscle, but you don't want that. And people actually have problems if they don't have enough fat if they're thin. But infection is also an issue, so you have to change the pump site every 2 to 3 days, and after that you get problems. So that's another management feature. The CGM stays people will use it off-label for up to a month or more. It starts, the adhesive comes off and all of that, but it doesn't get infected because it's sterile. So there's no fluid going in. It's just this really thin sensor. It technically could, but you're supposed to use alcohol to clean it, and so it's less likely unless you have an issue with the adhesive. But there are problems so the insulin will pool under the skin if you don't change the sites, and it doesn't absorb as well, and you can get scar tissue. You can get that with injections too, and that can become an issue over time if people don't rotate sites and kind of take care of that. So that is a self-management issue in addition, but that's not necessarily tied to the technology so much, because you get that with injections. Any way that you're injecting something frequently, you're going to get that. Okay, so this is the data that you'll get from the computer program for the Dexcom CGM. Each one of these dotted lines is a day. So this might be 2 weeks of data. So this is the green areas where the person should be. This is low, this is high. So if you got this, what would you do? Right, pretty hard to interpret this. You had like a bad day over here. You might look at like when that day was. You have time of day. So it's looking like, you know, at night it's higher, gets down during the day and goes up. So there's some like visual sorts of things you could look at, but there's a lot of variability. So on this day or this time of day, 3 p.m., you could have somebody that's down in the 30s, which is very dangerous, or up in the 350s, which is also dangerous. And so if you made some change on, you know, at 3 p.m., you might end up, you know, not doing the right thing, right? So you don't know how much is a trend or an individual pattern with this. So one sort of advance that's happened is there's this standardized way of reporting Cgm data that is more sort of user-friendly, both for the clinician but also through the patient. So this would be your average. The orange is your average value with standard deviation 1 or interquartile range and 2. So you can get a sense of that pattern, and these are individual day tracings. So you can see, is there a pattern on the weekends? Like Saturday looks like they're kind of staying high, whereas Sunday there's more fluctuation. What are they doing that might lead to that? And then summary statistics, like the average blood glucose, the percent of time low. Interestingly, this has norms on it. So the little numbers at the bottom, which you may not be able to see, are normal people wearing a sensor. So people do have variations in their blood glucose who don't have diabetes, but that below 54, that was 0 in the normative sample, so that should never happen to a normal person. But you will typically get some percentage, up to 5% of the time for most people with type 1 diabetes, and sort of the various other statistics and the amount of variation you get. So this is a little bit more user-friendly, but it still doesn't tell you what to do with that data. There's lots of ways you could address it. So one of the things IBM Watson has come up with this sort of algorithm decision aid that is with that integrated pump, so that has the CGM and the pump information. And they also, in this app, enter things like what they ate, the amount of carbs, fat content, that kind of thing. And then it will give you these insights based on that. So like having tuna salad, be aware that you tend to go low when you eat this meal. And then they'll give you some options of things that you could do on the pump specifically to address that. There's issues with FDA on this, so an app can't suggest, like, tell them what to bolus because that's dangerous. So they just sort of say, you might want to think about doing this, but we're not telling you to. If it goes wrong, don't blame us. And then it also looks at things like patterns at certain times of days and gives you statistics. So on Saturdays, you tend to go low. You might want to look at what you're doing on Saturdays. And their idea with this is to bring in other types of sensors, like activity sensors, so that if somebody is exercising more, that would factor into it too. Sleep, all of these sorts of things that could get at those 42 variables that affect blood sugar in a way that could actually be helpful for patients. But all of this depends on that sensor, which is less accurate in this model, and a lot of people won't use because it's not very accurate. Okay, so moving on to that question of what about cognitive impairment and what about older adults? So you probably have heard that type 2 diabetes is associated with risk for dementia and cognitive impairment. Type 1 diabetes is diabetes, so maybe that's the same. They're at risk for the same kinds of long-term complications like vascular disease, that type of thing. So it makes sense that that might also be a risk. But as I'll sort of show you, there's pretty limited evidence in type 1 diabetes. And then the question of if there is cognitive impairment, how does that impact somebody's self-management, and can technology address that, or will technology exacerbate a problem in this population? So why study older adults with type 1 diabetes? So we already talked about this, increasing incidence of type 1 diabetes across the board, so there's just more people, more adult diagnosis, longer life expectancy, better care. People are living longer with fewer complications, which means increasing number of older adults with type 1. So there was like zero research on older adults with type 1 diabetes before about maybe 10 years ago. Like it just is not. And even now, there's one longitudinal study just of 2 time points over 4 years with 80 people. And that's the only longitudinal data in an older adult population on cognition. So as I said, type 2 diabetes related to vascular and Alzheimer's dementia. There's lots of mechanisms by which that may happen, but it's not entirely clear. One of the mechanisms has to do with insulin resistance, in particular insulin resistance in the brain. And as I mentioned, type 1 diabetes does not typically have insulin resistance, so there's some sort of potentially differential mechanisms. Also, people, as you may have heard of, there's a trial for inhaled insulin for Alzheimer's disease, and people who don't have diabetes. And there's some data suggesting that insulin is a cognitive enhancer. So people who are taking insulin across their life there may be some protective value to that. But we just don't know. So there's enough question about the mechanism to suspect that there could be differences. Also, the duration of type 1 diabetes is typically much longer by the time a person is an older adult with type 1 versus type 2. And with type 2, you typically have a lot of other features, the metabolic syndrome type features that are associated with type 2 that are not always associated with type 1 that could increase your risk for brain injury. So it's important to look at type 1 specifically. There have been some data in children and younger adults. Meta-analysis showed there were some cognitive differences between people with diabetes type 1 and controls, but it's in the magnitude of 0.3 to 0.7 effect size. So group differences, but relatively mild. Tends to be associated with more of the complications. But in this meta-analysis, not severe hypoglycemic events, which people are always confused by because it's a dramatic event. You may have an outcome like where your dad had a head injury associated with that, so there's some cognitive consequence. But the event itself, some people will be completely unscathed. Other people may report problems, but there wasn't.
What about if they have such a severe episode where they are unconscious and therefore like oxygen's not getting to the brain?
Yeah.
Like, are they factoring? I mean, I know that not everyone gets to that point, but then.
Yeah. So there's a lot of difficulty with recording these,
Right, okay.
and they're relatively rare for a person to have like a severe episode that requires hospitalization or assistance from somewhere else, loss of consciousness. And then quantifying it, there's no GCS variable for this, and usually the person has a pretty rapid recovery because there are rescue approaches. So the degree of brain injury is just very difficult to quantify, and equating the spectrum of those events is difficult, and people are just not good at reporting them. So we have difficulty in the research of getting good measures of this because it's often, retrospective. And then there's some, so associated with microvascular complications, not severe hypoglycemia, A1C, which is a lab measure of average glucose over a 3-month period, in this meta-analysis was not related to cognition. But other more recent meta-analysis did find associations with hypoglycemia, longer diabetes duration, earlier age of onset, but it was variable across studies and populations. This study by Nunnally in 2015 was the only study prior to the one I'm going to talk about that actually looked at a clinical definition, so more of analogous to mild cognitive impairment in the sample versus just looking at mean differences between normal and type 1 diabetes. And they found 28% of their middle-aged cohort had clinically relevant cognitive impairment, which is higher than you'd expect, and they sort of postulated some advanced brain aging, potentially. It was associated with blood sugar control over the past 14 years. It was a longitudinal study that had one cognitive time point, but had a lot of medical data prior, and also these microvascular complications prior to that cognitive assessment, although they didn't have cognitive assessment prior, so they don't know in terms of change. There's this major study, cohort study, that called the Diabetes Control and Complications trial that was finished in '94, and it basically was testing whether getting people's blood sugar to a relatively normal level through multiple daily injections would result in improved outcomes. And this was in 1994 that they discovered that it was majorly, right? So before that, they didn't try to get people's blood sugar down to a normal level. They just tried to keep them out of the hospital. So people would have very high blood sugar that they wouldn't go into DKA, but they'd be really high. And they were getting lots of complications. So with this multiple injections at meals strategy, they were able to reduce complications by like 50% or some major number. And now things like blindness, retinopathy are pretty much non-existent until you get 20 plus years with diabetes based on this change in strategy. So it was really great for the field. They were worried about severe hypoglycemia with lowering people's blood sugars. So they gave this full neuropsych battery. And then they've followed them now since that time, and they're doing a new wave, and the sample is now average age in 60. So we're getting at some of the aging issues with this cohort, which will be really helpful. I've been helping with it, so I'm trying to get in. It's like this old, like it made people's careers, and they're all old guys now. So they're retiring, and I'm trying to sort of get in there. They found that over 18 years, so young adulthood to sort of middle-aged, that there were pretty minor cognitive changes associated with higher blood sugar and microvascular complications. They didn't find any relationship to severe hypoglycemia episodes, but I don't think they measured them very well. This sample also had an average IQ of 118 and like very educated, and it's 98% retention or something over 20, 30 years. So they're unique. It was a big investment. So there are no prospective longitudinal studies looking at dementia or MCI in type 1 diabetes. There was one sort of health system retrospective cohort from England, I believe, that did find a markedly increased rate of vascular dementia in people with a diagnosis of type 1 diabetes. And that was even compared to type 2. But there's just limited data in older adults with type 1. So I'm going to quickly go through this, so I only have 10 minutes. I underestimated how much I was going to talk. So this paper was just accepted, so it's no longer unpublished. So this is from a group that I work with that, so this is a relatively rare condition. There's probably only about 500,000 older adults with type 1 diabetes in the United States. So doing research is somewhat challenging. That number is obviously growing, but you have to work with big diabetes centers to be able to access this population. So the Type 1 Diabetes Exchange is a sort of nonprofit research-focused group that has this network of, I think it's like 72 diabetes centers in the United States and Canada, and we run studies through them. So this one was looking at risk factors for hypoglycemia in older adults, and we recruited from 18 centers, which was a challenge to train all those people on how to do neuropsych testing virtually, but we did. So average age in the sort of mid to late 60s, 60 to 86. Duration was average of 28 years. With some range there. So 74% of the sample had an adult onset, which is not typical of the overall population of type 1 diabetes. But if you survive to be old, you're more likely to have gotten it old. So there's a survivorship bias here. That may change over time with better care, certainly. We gave like the kitchen sink to these people because it was sort of an opportunity and looking at anything. It's not NIH funded, it's a private foundation, so they could do whatever they wanted. But we gave about an hour battery of cognitive tests, given that they were there for like 2 days for like 8 hours doing lots of other lab tests and everything. And so we only had a chunk. They wanted to give the MMSE, so I got them up to an hour. So not the optimal battery, but lots of questionnaires looking at all sorts of different things. We also had them wear a continuous glucose monitor for 2 weeks. And this is the first study to have that type of data with cognitive data as well to look at those metrics. So This is just the sample. There were no, so I divided the groups into like an MCI type algorithms consistent with that other paper. So on our battery, they had to have 2 or more tests out of 7 that were 1.5 standard deviations or lower below the published means. We found 48% of the sample was impaired by that metric. And comparing the 2 groups, there weren't any differences in basic demographics. It's an overwhelmingly white population, so 92% white, which is pretty typical of type 1 diabetes in general. Education, 25% at a graduate degree. So they're pretty highly educated that just go into these kinds of studies and do things like this, and who have survived to be this age. But no demographic history. So as I said, 48% of the sample met criteria for our criteria for mild cognitive impairment. They were selected from being independent, community dwelling, no diagnosis of dementia. I gave them a functional activities questionnaire, and they were all normal on that measure. So, and a quarter of them were impaired on more than half the tests. So it's pretty robust in terms of there being some significant signal here. Just from the literature, type 2 diabetes, about 30%. With MCI, normal adults, about 15 to 20% over age 60, so our population. So quite high. And then looking at that middle age sample with a very similar battery and kind of algorithm was 28%, so much higher in this older sample. And that not only sample was all child onset, which you would think would have more cognitive impairment. And then the profile, obviously it's a limited battery, and I'll show you what the tests were in a minute, but the majority, so amnestic MCI, which you would think more Alzheimer's risk, was relatively low, where they only had impairment on memory measures. The bulk of the battery was memory or executive processing speed type measures, meant to be sort of sensitive, and 44% had sort of a smattering. So fits with the vascular type profile. So these are the individual tests: Hopkins Verbal Learning Test, single-digit modalities, trails, and group pegboard. And the line there is just a score of 35, what you would expect in a normal sample. So Trails B was close to 40% of the sample was impaired on that test. A little less issue with memory tests, more the complex speeded processing. So the Cgm metrics, which I think are kind of interesting, there's not a lot of consensus on how you should analyze this data, and there's a lot of data. But looking at sort of the percent time below thresholds or above thresholds, average time, variability, looking at the day versus the night, sort of all these different ways of parsing the data. The things that stood out were, so I was interested in the night versus day because our things they're doing during the day may be putting them at more risk. But it turns out it's actually the opposite, that it's the nighttime that matters. And it's still what you do before you go to bed that's going to affect the night, but it's less sort of that mealtime decision making. So I wanted to look, I had hypothesized the time low would be a negative factor, but it's actually protective. And their average glucose was the higher, the more likely that they're cognitively impaired. But the more time they spent low at night, the less likely they were to be cognitively impaired. There are some theories that being mildly low can actually be neuroprotective, and the brain adapts and starts using other forms of fuel besides glucose. So the more time you spend low, there could be some protective effect of conditioning, hardening yourself to that condition, adapting to it. But it's probably more likely, given this is cross-sectional, that people who are not cognitively impaired are more likely to keep their blood sugar lower, and that will mean you have more time low. Versus if you're cognitively impaired, you're going to keep your blood sugar higher because it's safer, or your family or your physician is going to give you a higher target. So that might be more a reaction to cognitive impairment or lack thereof. But so A1C was related, but not that strongly. Hypoglycemia unawareness. So you mentioned your father, and also sort of this idea that you lose the symptoms. That was more common in people with cognitive impairment. And there's one other study that's found this as well. And there's some brain imaging studies looking at that there are some changes in your ability in the brain that may relate to your ability to detect these symptoms. But I think it's sort of more along the self-monitoring angle that people with cognitive impairment aren't noticing or interpreting the symptoms in the same way. So it may be an interesting finding. And then severe hypoglycemic events in the last year, but not lifetime, was pretty strongly and in dose-response fashion related. So in older adults, it may be more the recency of the event, or that they're more vulnerable, or it could be that it's recency regardless, because nobody's really looked at this even in younger people. They just ask for events and don't look at the time since the event. So it could be like they're having a brain injury and then recovering, or it could be that older brains just are more hit by it and less resilient. And then a microvascular complication of some kind was associated. But the things with the stars, those were, when looking at all of these things in the model, that were uniquely associated. So some CGM, some events, and these are not correlated, by the way. So the time that you spend low versus the actual severe event that lands you in the hospital and unconscious, those two aren't correlated, which people have a hard time with. But I think that it's probably more that the people who spend time low are cognitively able to correct and get themselves prevent an episode, whereas the cognitively impaired people are not. It may happen less often that they're low, but when they do, it's not good. So summary, not a lot of data on this. There's high levels of cognitive impairment in the sample, so we need to know more about it and how it affects their functioning. These are some things related to diabetes that we need to look at in terms of risk factors that may be somewhat unique in older adults, but we need to look at more in other samples. And this is a chicken or egg, or probably both, situation that cognitive impairment is probably causing poor blood glucose control, but then that poor blood glucose control is causing cognitive impairment. It's sort of this vicious cycle. And the question through trials that we need to do is to modify these variables and see if they affect cognition. So the trial, and I'm out of time, so I'll just tell you about it briefly, that I'm involved in right now, that we're almost done enrolling, is an older adult cohort, and we're randomizing them to CGM or not. So there's not been any studies that have looked at it in older adults. They usually exclude older adults in these studies. And so we're randomizing them 6 months, and then they can both get the sensor after the 6 months, so sensor or not. And we're testing their cognition at baseline, 6 months, and a year. And going to look at it in terms of a moderator. Are people with cognitive impairment, do they benefit more or less from the CGM? Do they need something else? So to your question. And then also looking at cognitive outcomes. So if we're able to, the goal of our study is to reduce hypoglycemia. So if we do that, do we see stability in cognition or improvement over that short time frame? Because we're finding that it is that short time frame that's affecting cognition. We're also, if you spend less time low, you're more likely to not have hypoglycemia unawareness. So a treatment for that is to keep someone's blood sugar out of the low range, so you lose that adaptation to it. So if through the trial we reduce hypoglycemia unawareness, we're going to be able to see if that affects cognition, sort of what that time course is. And then in our control group, we'll be able to just have some longitudinal data, just see what happens over this period. So we have 175, I think, people so far. Our target is 200. And we're going to start looking at the baseline data in the next couple weeks. I was hoping to have it by this, but we don't. So that is all I'm going to talk about. Any last questions in the 0 time that we have? Yeah.
A big, center then, or?
Yeah, so it's, let me see. I actually had quite a bit more that I was going to talk about. But oh, whoops. Here it is. So it's 22 clinical sites, same group that we're recruiting from. We actually started recruitment in October and have the people already. So they're pretty insane how good they are at this. But each site has like 9 people. So they have this big database registry of 30,000 adults and children with type 1 diabetes in the United States, and they can kind of query and find all the people that match.
That it works so well that they thought a system, because that's the only way you're going to be able to do this at least.
Yeah. So we're submitting a bunch of other grants too. And one of the questions, so we're going to submit a grant to follow up on this, to look at the cognitive impairment question. There's these integrated